Welcome to this comprehensive lecture on renal transplantation in children. I am Dr. Abdelaziz Yousef, and this presentation is brought to you by Pediatric Case Review. Throughout this lecture, we will explore 14 clinical scenarios designed to provide you with a solid foundation in pediatric renal transplantation. We will cover epidemiology, indications, pre-transplant evaluation, surgical procedures, complications, and long-term outcomes. Each case has been carefully crafted to highlight key clinical considerations you will encounter in your practice. Let us begin this educational journey together. This lecture will follow a structured case-based approach with 14 clinical scenarios. Each scenario has been designed to test your knowledge and understanding of key aspects of pediatric renal transplantation. We will cover everything from epidemiology and indications through to long-term outcomes and quality of life considerations. The content is specifically tailored for pediatric residents and fellows at an introductory level. By the end of this presentation, you will have a comprehensive understanding of the critical considerations in managing children requiring renal transplantation. An 8-year-old child presents with fatigue, pallor, and decreased appetite. Laboratory investigations reveal a glomerular filtration rate of 12 milliliters per minute per 1.73 square meters. The child has been under nephrology care for chronic kidney disease. What is the stage of chronic kidney disease and appropriate management approach? Option A, Stage 3 chronic kidney disease requiring medical management and monitoring. Option B, stage 4 chronic kidney disease requiring preparation for renal replacement therapy. Option C, Stage 5 chronic kidney disease requiring immediate renal replacement therapy. Option D, Stage 2 chronic kidney disease requiring conservative management only. The correct answer is C, Stage 5 chronic kidney disease requiring immediate renal replacement therapy. Chronic kidney disease staging is based on glomerular filtration rate. A GFR of less than 15 milliliters per minute per 1.73 square meters indicates Stage 5 chronic kidney disease, also known as end-stage renal disease. At this stage, renal replacement therapy becomes necessary. The options include hemodialysis, peritoneal dialysis, or renal transplantation. Transplantation offers the best long-term outcomes and quality of life for children with end-stage renal disease. The other options are incorrect because they represent different GFR ranges. Stage 2 has GFR greater than 60, Stage 3 has GFR 30 to 59, and Stage 4 has GFR 15 to 29. This table provides a comprehensive overview of chronic kidney disease staging based on glomerular filtration rate. Stage 1 and 2, with GFR greater than 60, require only monitoring. Stage 3, with GFR 30 to 59, requires medical management. Stage 4, with GFR 15 to 29, requires preparation for renal replacement therapy. Stage 5, with GFR less than 15, requires immediate dialysis and transplantation. Epidemiologically, pediatric end-stage renal disease affects approximately 5 to 10 children per million population annually. The outcomes are promising, with 5-year graft survival rates exceeding 80% with living donor transplants. Understanding these stages is crucial for appropriate management and timely intervention. A 5-year-old boy has been diagnosed with bilateral dysplastic kidneys since infancy. He now presents with growth failure, hypertension, and laboratory investigations show a glomerular filtration rate of 10 milliliters per minute per 1.73 square meters. Which of the following is the most appropriate indication for renal transplantation in this child? Option A, wait until the child reaches 10 years of age for better surgical outcomes. Option B, end-stage renal disease due to congenital kidney dysplasia. Option C, initiate hemodialysis first and consider transplantation after 1 year. Option D, transplantation is contraindicated due to congenital abnormalities. The correct answer is B, end-stage renal disease due to congenital kidney dysplasia. This child has end-stage renal disease secondary to congenital bilateral dysplastic kidneys. Congenital causes are among the most common indications for renal transplantation in children. Common congenital causes include polycystic kidney disease, dysplastic kidneys, Alport syndrome, and congenital obstructive uropathy. Common acquired causes include obstructive uropathy, malignancy, systemic lupus erythematosus, and glomerulonephritis. The other options are incorrect because age alone is not a contraindication. Transplantation can be performed in young children. Preemptive transplantation before dialysis offers better outcomes, and congenital abnormalities are common indications, not contraindications. A 10-year-old girl with end-stage renal disease is being evaluated for renal transplantation. She has been on hemodialysis for 6 months. Her medical history includes hypertension controlled with medications and anemia managed with erythropoietin. Which of the following investigations is essential in the pre-transplant evaluation? Option A, basic metabolic panel and complete blood count only. Option B, comprehensive evaluation including renal function, imaging, and immunological assessment. Option C, psychological evaluation and family assessment only. Option D, cardiac evaluation and pulmonary function tests only. The correct answer is B, comprehensive evaluation including renal function, imaging, and immunological assessment. Pre-transplant evaluation requires a comprehensive multidisciplinary approach to ensure optimal outcomes and identify potential contraindications. Essential laboratory tests include renal function tests, complete blood count, coagulation profile, bone profile, and vitamin D assessment. Important imaging studies include abdominal ultrasound, DMSA scan, MCUG if indicated, X-ray wrist for rickets, and renal biopsy if needed. Immunological assessment includes HLA typing, panel reactive antibody, cross-matching, viral serology, and blood group compatibility. The other options are incomplete because basic metabolic panel and CBC alone are insufficient. Psychological evaluation is important, but not the only essential component, and cardiac evaluation is crucial but part of a broader assessment. This comprehensive pre-transplant evaluation checklist includes all essential investigations required before listing a child for renal transplantation. Laboratory investigations include renal function tests, hematology, bone profile, immunological assessment, and infectious disease screening. Additional assessments include imaging studies, cardiac evaluation, pulmonary evaluation, psychosocial assessment, and necessary consultations. The checklist ensures that no critical component is missed in the evaluation process. It is important to note that all investigations must be completed before listing for transplantation to ensure the child is medically optimized and any potential contraindications are identified early. This systematic approach helps improve transplant outcomes and reduce postoperative complications. A 7-year-old boy with end-stage renal disease requires renal transplantation. Potential donors include his 25-year-old brother, HLA matched, his 45-year-old father, partially matched, and a deceased donor with good HLA match. Which donor would provide the best outcome for this child? Option A, deceased donor with good HLA match. Option B, living related donor with HLA matching. Option C, living unrelated donor with partial match. Option D, any donor is equivalent in pediatric transplantation. The correct answer is B, living related donor with HLA matching. Living related donors with HLA matching provide the best outcomes in pediatric renal transplantation. The combination of genetic similarity and the advantages of living donation contribute to superior graft survival. Advantages of living donors include better HLA matching, reduced cold ischemia time, elective timing, lower rejection rates, and longer graft survival. Donor selection criteria include HLA compatibility, ABO blood group match, negative cross-match, age appropriateness, and medical fitness. The other options are less optimal because deceased donors have longer cold ischemia times and potentially less optimal HLA matching. Living unrelated donors may have poor HLA matching, and donor selection significantly impacts outcomes in pediatric transplantation. A 6-year-old girl is scheduled for renal transplantation from her living related donor. The surgical team is planning the operative approach considering the child's size and anatomical considerations. What is the most appropriate surgical approach for pediatric renal transplantation? Option A, intraperitoneal placement in the left upper quadrant. Option B, extraperitoneal placement in the right iliac fossa. Option C, orthotopic placement in the renal fossa. Option D, retroperitoneal placement in the pelvis. The correct answer is B, extraperitoneal placement in the right iliac fossa. The standard surgical approach for pediatric renal transplantation is extraperitoneal placement in the right iliac fossa. This location provides optimal exposure for vascular anastomosis and allows for easy access in case of future interventions. Surgical advantages include excellent exposure of iliac vessels, easy access for ultrasound monitoring, simple wound closure, minimal risk of bowel injury, and standardized approach. Technical considerations include arterial anastomosis to external iliac artery, venous anastomosis to external iliac vein, ureteroneocystostomy for drainage, size-appropriate vessel anastomosis, and careful hemostasis. The other options are incorrect because intraperitoneal placement risks bowel complications and adhesions. Orthotopic placement is technically challenging and rarely performed, and retroperitoneal pelvic placement offers no advantages over standard approach. This slide illustrates the surgical anatomy and approach for pediatric renal transplantation. The kidney is placed in the right iliac fossa using an extraperitoneal approach, positioned anterior to the psoas muscle. The arterial anastomosis is performed intuside to the external iliac artery, while the venous anastomosis is intuside to the external iliac vein. Urinary drainage is achieved through ureterocystostomy with stent placement. The surgical incision is typically a hockey stick or Gibson incision. Post-surgical scar appears in the right lower quadrant, which is easily accessible for ultrasound monitoring and biopsy procedures. This standardized approach has been proven to provide excellent outcomes with minimal complications in pediatric patients. A 6-year-old boy underwent renal transplantation 8 hours ago. He is in a pediatric intensive care unit with stable vital signs. His urine output has been 20 milliliters per hour for the past 2 hours. What is the most critical aspect of immediate postoperative management? Option A, aggressive fluid resuscitation to increase urine output. Option B, careful fluid management, monitoring, and immunosuppression. Option C, immediate administration of high-dose steroids. Option D, routine postoperative care without specific monitoring. The correct answer is B, careful fluid management, monitoring, and immunosuppression. The immediate postoperative period is critical for graft survival. Careful fluid management, close monitoring, and appropriate immunosuppression are essential components of perioperative care. Fluid management involves balancing hydration status, monitoring urine output, avoiding fluid overload, and electrolyte replacement. Monitoring includes vital signs hourly, strict urine output measurement, graft ultrasound, and renal function tests. Immunosuppression includes induction therapy, maintenance dosing, therapeutic level monitoring, and toxicity monitoring. The other options are incorrect because aggressive fluid resuscitation may cause pulmonary edema in anuric patients. Steroids are part of immunosuppression, but not the only critical component, and routine care, without specific monitoring, risks missing early complications. A 9-year-old girl underwent successful renal transplantation 2 weeks ago. She is now ready for maintenance immunosuppression therapy to prevent rejection. What is the standard triple therapy immunosuppression regimen for pediatric renal transplant recipients? Option A, calcineurin inhibitor, antimetabolite, and corticosteroids. Option B, high-dose steroids alone. Option C, antimetabolite and corticosteroids only. Option D, calcineurin inhibitor and corticosteroids only. The correct answer is A, calcineurin inhibitor, antimetabolite, and corticosteroids. The standard maintenance immunosuppression for pediatric renal transplant recipients is triple therapy consisting of a calcineurin inhibitor, an antimetabolite, and corticosteroids. Calcineurin inhibitors include tacrolimus as first choice and cyclosporin as alternative, requiring blood level monitoring and carrying nephrotoxicity risk. Antimetabolites include mycophenolate mofetil and azathioprine as alternative, with risks of myelosuppression and gastrointestinal side effects. Corticosteroids include prednisone or prednisolone, tapered over time, with risks of growth suppression and metabolic effects. The other options are incorrect because high-dose steroids alone are insufficient for long-term rejection prevention. Double therapy omitting calcineurin inhibitor increases rejection risk, and double therapy omitting antimetabolite also increases rejection risk. This comprehensive immunosuppression management table provides essential information for pediatric renal transplant recipients. Tacrolimus is dosed at 0.1 to 0.3 milligrams per kilogram per day divided twice daily, with trough levels monitored between 5 to 15 nanograms per milliliter, and potential side effects include nephrotoxicity, neurotoxicity, and diabetes. Mycophenolate is dosed at 600 to 1200 milligrams per meter squared per day divided twice daily, with complete blood count monitoring weekly then monthly, and side effects include leukopenia, gastrointestinal upset, and infection risk. Prednisone starts at 2 milligrams per kilogram per day and tapers to 0.1 milligrams per kilogram per day, with monitoring of growth, blood pressure, and blood glucose, and side effects include growth suppression, weight gain, and osteoporosis. A 6-year-old boy, 5 days post-renal transplantation, presents with decreased urine output from 100 milliliters per hour to 20 milliliters per hour over the past 12 hours. His creatinine has risen from baseline 1.2 to 2.5 milligrams per deciliter. What is the most likely cause and appropriate initial management? Option A, acute rejection requiring immediate biopsy and steroid pulse. Option B, urinary obstruction requiring urgent ultrasound evaluation. Option C, calcineurin inhibitor toxicity requiring dose reduction. Option D, dehydration requiring aggressive fluid resuscitation. The correct answer is B, urinary obstruction requiring urgent ultrasound evaluation. In the early postoperative period, first week, technical complications such as urinary obstruction are common causes of decreased urine output and rising creatinine. Ultrasound is the initial diagnostic test of choice. Early postoperative complications include urinary obstruction, most common, vascular thrombosis, lymphocele, urine leak, and hematoma. The diagnostic approach includes immediate ultrasound as first step, Doppler flow studies, urine electrolytes, renal function trend, and consideration of biopsy if ultrasound is normal. The other options are less likely because rejection typically occurs later, after 1 week. Calcineurin toxicity usually develops over weeks, and dehydration would respond to fluid challenge. Early recognition and management of technical complications are crucial for graft survival. A 7-year-old boy, 3 months post-renal transplantation, presents with fever of 39 degrees Celsius, cough, and dyspnea. His chest X-ray shows bilateral interstitial infiltrates. What is the most likely diagnosis and appropriate management? Option A, bacterial pneumonia requiring broad-spectrum antibiotics. Option B, cytomegalovirus infection requiring ganciclovir. Option C, pneumocystis jirovecii pneumonia requiring high-dose trimethoprim sulfamethoxazole. Option D, acute rejection requiring steroid pulse and biopsy. The correct answer is B, cytomegalovirus infection requiring ganciclovir. Cytomegalovirus infection is one of the most common opportunistic infections in the first year after renal transplantation, typically presenting between 1 to 4 months post-transplant, with fever and pulmonary symptoms. Common infections include CMV, most common, pneumocystis jirovecii, EBV, BK virus, and fungal infections. CMV management includes ganciclovir or valganciclovir, reduction of immunosuppression, monitoring CMV viral load, and consideration of intravenous immunoglobulin for severe cases. The other options are less likely because bacterial pneumonia typically presents with lobar infiltrates, not interstitial. PJP is possible but less common than CMV at 3 months, and rejection typically presents with renal dysfunction, not respiratory symptoms. CMV and PJP are the most common causes of death in the first year after transplantation. This timeline illustrates the pattern of post-transplant infections and prophylaxis strategies. The first 1 to 4 months represent the CMV period with peak risk for cytomegalovirus, Epstein-Barr virus, and fungal infections. 2 to 6 months represent the PJP period with risk for pneumocystis jirovecii pneumonia. 6 to 12 months represent the late period with community infections, BK virus, and late CMV. Prophylaxis regimens include valganciclovir for 3 to 6 months for CMV prevention, trimethoprim sulfamethoxazole for 6 to 12 months for PJP prevention, fluconazole as needed for fungal prevention, and monitoring of Epstein-Barr virus viral load. Important vaccination considerations include that live vaccines are contraindicated, inactivated vaccines are safe, household contacts should be vaccinated, and annual influenza vaccine is recommended. Understanding this timeline helps in early recognition and management of post-transplant infections. An 8-year-old girl, 3 weeks post-renal transplantation, presents with rising creatinine from baseline 1.0 to 2.2 milligrams per deciliter over 5 days. She has mild graft tenderness, but no fever. What is the most likely diagnosis and appropriate management? Option A, acute cellular rejection requiring steroid pulse therapy. Option B, calcineurin inhibitor toxicity requiring dose reduction. Option C, urinary tract infection requiring antibiotics. Option D, dehydration requiring fluid resuscitation. The correct answer is A, acute cellular rejection requiring steroid pulse therapy. Acute cellular rejection typically occurs between 1 week to 3 months post-transplant. The presentation with rising creatinine, graft tenderness, and absence of fever is classic for acute rejection. Types of rejection include hyperacute, immediate, acute cellular, 1 to 12 weeks, antibody-mediated, variable, and chronic, greater than 3 months. Management approach includes confirmation with biopsy, steroid pulse therapy, consideration of ATG for severe cases, and optimization of maintenance immunosuppression. The other options are less likely because calcineurin toxicity usually develops more gradually and without graft tenderness. UTI typically presents with fever and urinary symptoms, and dehydration would respond to fluid challenge and not cause graft tenderness. Early recognition and treatment of acute rejection are crucial for long-term graft survival. This comprehensive table outlines the different types of rejection in pediatric renal transplantation. Hyperacute rejection occurs within minutes to hours, is caused by preformed antibodies, presents with immediate graft failure, and requires graft removal and plasmapheresis. Acute cellular rejection occurs 1 to 12 weeks post-transplant, presents with rising creatinine, graft tenderness, and possible fever, and is treated with steroid pulse and ATG for severe cases. Antibody-mediated rejection has variable timing, is associated with donor-specific antibodies and vascular inflammation, and is treated with plasmapheresis, intravenous immunoglobulin, and rituximab. Chronic rejection occurs after 3 months, presents with gradual dysfunction, proteinuria, and hypertension, and requires optimization of therapy, management of complications, and consideration of retransplantation. Biopsy findings and post-rejection monitoring strategies are also essential components of rejection management. A 12-year-old boy, 3 years post-renal transplantation, presents with poorly controlled hypertension despite multiple antihypertensive medications. He also has growth delay and is below the 3rd percentile for height. What is the most appropriate management approach? Option A. Comprehensive approach including medication adjustment and growth hormone evaluation. Option B. Increase steroid dose to improve growth. Option C. Discontinue all immunosuppression and prepare for retransplantation. Option D. Add more antihypertensive medications without addressing growth issues. The correct answer is A. Comprehensive approach including medication adjustment and growth hormone evaluation. Long-term complications after renal transplantation include hypertension, growth failure, and medication side effects. A comprehensive approach addressing all issues is essential for optimal outcomes. Common long-term issues include hypertension from calcineurin inhibitors, growth failure from steroids, metabolic complications, malignancy risk, and chronic rejection. Management strategies include minimizing steroid dose, considering growth hormone therapy, optimizing antihypertensive regimen, regular screening for complications, and multidisciplinary care. The other options are incorrect because increasing steroid dose would worsen growth failure, discontinuing immunosuppression would lead to graft loss, and addressing only hypertension ignores the growth issue. A balanced approach addressing all long-term complications is crucial for the child's overall health and development. A 9-year-old girl, 2 years post-renal transplantation, has poor growth velocity. Her height is below the 5th percentile, and she has grown only 2 centimeters in the past year despite adequate nutrition. What is the most appropriate management strategy for her growth failure? Option A. Comprehensive approach including steroid minimization and growth hormone therapy. Option B. Increase caloric intake only. Option C. Discontinue all immunosuppression to improve growth. Option D. No intervention as growth failure is expected after transplantation. The correct answer is A. Comprehensive approach including steroid minimization and growth hormone therapy. Growth failure is a common complication after pediatric renal transplantation, primarily due to chronic steroid use. A comprehensive approach addressing all contributing factors is essential. Causes of growth failure include chronic steroid use, primary, reduced growth hormone secretion, chronic kidney disease effects, nutritional deficiencies, and delayed puberty. Growth management strategies include steroid minimization or withdrawal, growth hormone therapy, nutritional optimization, correction of metabolic acidosis, and management of renal osteodystrophy. The other options are incorrect because increased calories alone won't address steroid-induced growth suppression. Discontinuing immunosuppression risks graft rejection, and growth failure should be actively managed, not accepted as inevitable. Early and aggressive management of growth failure is crucial for achieving normal adult height and quality of life. A 14-year-old boy, for years post-renal transplantation, has poor medication adherence. He frequently misses doses of immunosuppressants and has had 2 rejection episodes in the past year. He struggles with body image issues and feels different from his peers. What is the most appropriate approach to address his adherence issues? Option A. Multidisciplinary approach including psychology and peer support groups. Option B. Punitive measures including hospitalization for non-adherence. Option C. Transfer care to adult services immediately. Option D. Discontinue transplantation and return to dialysis. The correct answer is A. Multidisciplinary approach including psychology and peer support groups. Adolescents face unique psychosocial challenges after transplantation. A supportive, multidisciplinary approach addressing psychological, social, and educational needs is most effective. Psychosocial challenges include body image concerns, feeling different from peers, medication burden, school attendance issues, and transition to independence. Support strategies include psychological counseling, peer support groups, school liaison programs, transition preparation, and family education and support. The other options are inappropriate because punitive approaches damage trust and worsen adherence. Immediate transfer to adult services lacks preparation and returning to dialysis reduces quality of life significantly. A supportive approach that addresses the underlying reasons for non-adherence while providing the necessary support systems is most likely to succeed in the long term. A 4-year-old girl with end-stage renal disease has multiple comorbidities including severe congenital heart disease, developmental delay, and failure to thrive. Her parents are requesting renal transplantation evaluation. What is the most appropriate approach to this ethical dilemma? Option A, multidisciplinary team approach with comprehensive evaluation and family involvement. Option B, immediate denial based on multiple comorbidities. Option C, automatic approval to honor parental request. Option D, referral to ethics committee without further evaluation. The correct answer is A, multidisciplinary team approach with comprehensive evaluation and family involvement. Complex pediatric transplant cases require a careful, multidisciplinary approach that balances medical feasibility, ethical considerations, quality of life, and family values. Ethical considerations include resource allocation justice, best interest of the child, quality of life assessment, medical feasibility, and family autonomy. The decision-making process includes comprehensive medical evaluation, multidisciplinary team discussion, family counseling and education, risk-benefit analysis, and ethics committee consultation if needed. The other options are inappropriate because immediate denial without evaluation may miss potential for successful outcome. Automatic approval ignores medical and ethical considerations, and ethics committee referral should follow, not replace, comprehensive evaluation. A balanced approach that thoroughly evaluates all aspects of the case while respecting family input is essential for ethical decision-making in complex pediatric transplant cases. Thank you for joining me in this comprehensive lecture on renal transplantation in children. We have covered 14 clinical scenarios highlighting key aspects from epidemiology and indications through to long-term outcomes and ethical considerations. Remember that pediatric renal transplantation requires comprehensive evaluation and multidisciplinary care. Early recognition and management of complications improve long-term outcomes, balance immunosuppression efficacy with side effect management, and address psychosocial and developmental needs for optimal quality of life. Please subscribe to Pediatric Case Review for more informative presentations and feel free to comment with any questions or feedback. This is Dr. Abdelaziz Yousef signing off.